Our next panel is a discussion that's got a lot of media coverage these days, PPNs, Preferred Pharmacy Network. So this should be a hot topic, and we're going to leave it, I'll leave it to our moderator. She's going to introduce herself and the panelists. Come on up and let's go.
Okay.
Oh.
Good morning, everyone. Yep, we're still morning, which is good. And I know that we are the panel right before lunch as well, so we'll make sure that we're informative and create a good discussion. My name is Uchenwa Genus. I'm the VP for Specialty Pharmacy at McKesson Canada. And today we do have the panel on PPNs. I do want to introduce our lovely panelists and Bruce to everyone. So I'll start off. I'll introduce Bruce first. So Bruce is the Senior Director for Pharmacy Advocacy and Professional Affairs with Neighbourhood Pharmacy. Very important voice and perspective to bring to the PPN discussion as he leads a very large retail community pharmacy network in Canada. You're very welcome, Bruce.
Thanks.
I'll next introduce Stephanie Babbitt. Stephanie is the lead for patient support services with Dupixent at Sanofi. And so Stephanie definitely brings a wealth of experience from her patient support program perspective in pharma, and we'll have a great debate with some of her insights. And last but not the least, I'll introduce Sandra Hanna. Sandra is the CEO of Neighbourhood Pharmacy Association of Canada. We all know NPAC and the role they do in terms of advocacy and representing over 12,000 pharmacies across Canada. So certainly a great perspective to bring to this panel. So we'll get started. Preferred Pharmacy Networks. I'm sure that we're all at the edge of our seats because we know that PPNs have been around for a very long time. There's different types of constructs of PPNs, open, closed, and we know that just recently there's been a huge debate and a large controversy around PPNs, and so that's what we're here to dig into. I'll direct my first question to you, Stephanie. Could you share what you think are some of the complexities that are involved in the current PPN debate?
Sure. I mean, I think I echo what was said in one of the last panels, which is when you look at things in isolation, you don't get the big picture. And patient support programs, as we all know, fill a gap in the existing healthcare system, but it's also part of a business, the same way a pharmacy is part of a business and the insurance providers are part of a business. And so our role is really to fill the gap for the patients who are part of that PPN. Where the complexities can come in is if patients are not able to choose the pharmacy that they normally choose. And so one of the evolutions of specialty pharmacies as part of patient support programs over the last several years is that it's no longer all of your dispenses happen here. That was the model 10 years ago, and now it's very much more open choice for patients. These specialty molecules are much more comfortable in the hands of retail pharmacists these days, and so there's a lot of ability for patients to go where they want to. So when they have a PPN in place and they're not allowed to use their pharmacy of choice, we have to work with the patient to negotiate with them on the best interests. Depending on the design of the plan, they may have, I guess you might call it an open plan, where if you go to pharmacy A, you're covered at 80%. If you go to pharmacy B, your choice, you get it at 40%. And so it's really about how do we support the patient to understand what's best for them to help them get access. So it's deeper conversations. It's conversations that we wouldn't necessarily have had in the past, but they're really important so that patients can get the benefit of therapy.
Thanks for that, Stephanie. Maybe I'll pose a follow-up to that, to the larger group in terms of PPNs impacting patient access. Wondered what your thoughts are on how patients view that statement or comment, or pharmaceutical manufacturers and how they view that.
So our patients, some of them just don't care. And When I say that, they're so desperate for treatment. I mean, specialty medications are not for patients that are doing really well. They're for people who are suffering in some way, shape, or form. And so really getting the drug is important for them. For that smaller subset that really do care about where they're getting it from, again, it's an impact, it's a disruption to how they experience and control their own health care. And I think it really has to be an individual patient approach to how we support them. So it's not our job in the patient support program to advocate on one side or the other. It's really to help that patient in the journey. So there are those difficult conversations that do have to happen, and for the patient's difficult decisions. But honestly, it's not a huge, overwhelming issue and barrier that we have, because patient support programs are really good at navigating these now.
Excellent, thanks for that. I'll open it up for any other comments from the panel.
I guess I'll make one comment. I think this really points to the complexity of the space. I mean, PPNs, they don't exist in isolation, especially when we think, I mean, they do exist for all medications, but when we think about specialty medications, they certainly do not exist in isolation because they have to interact with PSPs. And so when we think about PPNs as sort of, insurer-driven or employer-driven, I think we have to think about whether they're driven for patient services, because to your point, when we think about PSPs and some of the services surrounding some of the therapies that may or may not be included in these PPNs, patients really value and need some of these services. But then when we think about some other PPN models or designs that are more cost-related, the patient really doesn't see the difference. Then it's purely just impacting their choice. And your commentary around, it may be covered at 80% at one pharmacy and 40% at a pharmacy that's not within the PPN, one might argue whether that's really choice. Especially when we think about, specialty medications. If I'm on a $10,000 drug and, I'm getting covered 80% in one place and 40% in another, do I truly have a choice? One might argue that. So I think it just sort of points to the complexity, especially when we start to think about the interdependency with PSPs and specialty medications.
That's a good point, Sandra, that you raised around patient choice, and we'll certainly get to that further in the discussion. Bruce, maybe I'll pose a question to you. So some have referred to PPNs as payer-directed care. Is that an accurate description?
Yeah, I think that it's perhaps a more accurate description for me about what a PPN is. I am, an advocate for patients, patient choice, patient access, and for the profession of pharmacy. And any time that a payer creates an incentive or a disincentive, I guess, could be as well, for a patient to choose from which pharmacy or pharmacist that they receive their care, then to me that is payer-directed care. And I'm very clear in my position. While I totally agree with Sandra that it's complex, I am opposed to payer-directed care, other than in some rare and exceptional circumstances where we've heard some of the cost of therapy for rare diseases or perhaps even an example like we saw at the beginning of COVID when vaccinations came out, and there were some stability issues that needed an ultra-frozen state. Well, pharmacies normally don't have an ability to store something in an ultra-frozen state. So I think if we could just keep it simple to patient choice, which I think most people in this room would agree that that's the best goal. Everything else to me is payer-directed care.
So thanks for that response, Bruce. I think when we think about payers and their perspectives on PPNs, certainly there's a perspective around sustainability and maybe cost containment in order to manage, the sustainability of their plans, and therefore the plans of the plan members and the plan sponsors that they are, really charged to support. So maybe I'll pose this question to you, Sandra. Do payers understand what they're paying for when they look at their drug budget lines?
Well, I'm not sure. We have this conversation with public payers as well on a regular basis. We heard from the last panel, how much drugs have changed over the number of decades. Drugs used to be much simpler, much lower in cost. Certainly with the trends that we're seeing in drug prices, specialty medications, we can appreciate the pressures on employers and payers. But I think what has really shifted is historically, and maybe I'll take it back a second to just sort of share how pharmacies are funded. So first of all, the majority of pharmacies in our country are actually independently owned or primarily sort of, dispensary focused. Like they're not, your big mass merchandisers, grocers. Those are certainly the bigger players, but that's not actually the majority of storefronts when we look at our country. And so for the majority of the pharmacies, actually more than 80% of the funding that a pharmacy relies on to pay their rent, pay their staff, hold their inventory, provide all the services, keep their doors open in communities that serve the majority of Canadians. 95% of Canadians live within 5 kilometers of a pharmacy. That is all funded through dispensing services. Now, on average, dispensing fees are about $10. And then, yes, there's some margin on the related to the drug price, but we are seeing more and more pressure on those markups. We are seeing more and more caps, like hard dollar caps. We heard at the last panel, the impact of inflation is affecting us all in terms of our cost of operations, but pharmacies have not seen any increase in their fees. So I think there's an important discussion that doesn't get had enough around the sustainability of the pharmacy sector. Pharmacies are in virtually every community. They serve a really important role. The brick and mortar, although, we can debate the topic of what Canadians want and what consumers want in terms of online and convenience and at your doorstep versus brick and mortar. The reality is people see their pharmacist 10 times more frequently than any other touch point in the healthcare system. So having those brick and mortars in every community across the country is critical, not only for medication access, but for care access. And we are seeing more and more, just as the private sector and the private payers are filling important gaps in the healthcare system, pharmacies are filling really, really important gaps in the healthcare system as well, whether it be primary care services, prescribing for common ailments that otherwise employees or plan members or patients would be going to the Emerge for, or going to walk-in clinics for, or spending full days, in a walk-in clinic or an emergency room. Now they can access those services in their pharmacies. Pharmacists are playing much greater roles in chronic disease management. Pharmacists are, I think it was Martin who mentioned, the complexity of our system, and we are all experts in this system, and we all experience complexities navigating our system. Pharmacists being that first touch point with the healthcare system, pharmacists are playing a huge role in helping patients navigate the healthcare system, whether it be their coverage, whether it be where they can access care, how they can access care. So I share all that because all of those services are funded through dispensing fees and dispensing revenue and funding. And so when we look at a drug budget, we think drug, but all of that goes behind that. And the ability for pharmacies to continue to operate in every community, to be that accessible touch point with the healthcare system, is all funded through the pharmacy part of that drug budget that payers look at. So I don't think that payers think frequently enough about what they are paying for, because we are still lumped in. Pharmacy services are often still lumped in for the most part. Yes, there are some additional service fees around, medication reviews, but it's still the very small minority of the funding that pharmacies rely on to keep their doors open.
Well, thanks for that, Sandra. It's interesting that I think when we think payers and the pressures on pharmacy, there's public payers, there's private payers, there's sort of different sort of stakeholders that affect reimbursement. Just a follow-up, I think, what do you think that we could do to help share that message or spread that message about the balance between what is a drug cost versus what is a wraparound patient service that might be needed for a complex patient, like a rare patient, or those types of patients that it's not just putting pills in a bottle and shipping it out the door.
Is that to me? So I think we all have a responsibility here. I think every manufacturer in this room probably has this same conversation when you're having market access discussions. It's not just a drug, it's the value and what's the, stop thinking about the cost, we need to think about value. But I think there's collaboration opportunities between the providers, so pharmacy, I can speak for our own organization, pharmacies and manufacturers to better align on that messaging. Because certainly there is, from each manufacturer's perspective, the value that your drug brings, not only in that condition or the treatment and therapy, but also in ensuring that person is well, and their quality of life and their productivity, their ability to work. Those are all really important conversations to have, but how do we also wrap around what are the services that patients need to ensure the best patient outcomes on each of those medications? And the reality is a lot of those services are managed and overseen by pharmacies or patient support programs. You can probably speak to that too. But I think there's an opportunity for us to coordinate some of that messaging in all of our discussions, whether it be with public payers or private payers, because there is a whole sort of supply chain that happens between sort of the drug, the manufacturer, and then all the way down. Angelique yesterday talked about the distribution, and then to the pharmacy, and then the services that are required by the pharmacy or the PSP to actually ensure that patients not only get their medications, but also get the best value out of their medications.
Yeah, and I would add from that wraparound service, you're right, there's so much that is done by a patient support program. I mean, they're all designed slightly differently, but really they're there to support and educate the patient, help them get reimbursement. When the patient has the benefit of a strong PSP team, as well as the collaboration with the pharmacist, they're going to get the best out of their therapy. And while, again, I'm not one way or the other about the value of PPNs in general, we do know that when the patient has the opportunity to speak to a pharmacist who's been educated about the disease state, who's been educated about the medication, they may have incremental ability to train and coach and educate that patient. The PSPs don't have that opportunity to engage with the community pharmacists in the same way. And so there's gaps everywhere. And so, and this is nothing against pharmacists, they're all brilliant, and they know how to take care of their patients, but we all know that doctors aren't experts in every area, so how can pharmacists be experts in every area? So it's a fine balance, and if we had a magic wand, we would wipe the slate clean and look from the patient perspective up and build things that way. But we are a commercial society. We're built as pharmacy as a business, insurance as a business, employers who need plans as a business, pharma as a business. So until we can actually truly break down all of those silos and come together, then PPNs are a reality. We heard earlier, I think it was Martin talking about, he addressed the question about the 33% low max. And if I have to compare our patients who come through our program that have a PPN versus those that have a low max, there's no question that those with a low max are disadvantaged. And so when we're looking at what are the options for insurance providers to keep premiums low for their employers, to give the most access as possible, from a PSP perspective, let's get rid of the low max plans and find ways to collaborate differently. And if that means we have to collaborate along PPNs, then we'll do it, because that's, from our side, what's best for the patient.
And so thanks for that, Stephanie. Appreciate it. Bruce, I'd like to pull you into the discussion and just talk about pharmacies. Like from a retail pharmacy perspective, there's obviously comments around and thoughts around what pharmacy can do or can't do or how they can support in the space. And also thinking about the sustainability of pharmacy as a business. Sandra called out as pharmacies are a critical point of access for patients to access care in the community. So keeping a very healthy, thriving pharmacy network is important for Canadians. So I'd like to bring you in to weigh in on comment from a retail perspective.
Yeah, thanks. Well, it's hard for us to separate PSPs from PPNs because they overlap,
Yeah.
right? And I would say that, generally a stated goal of a PPN is to somehow deliver cost control to the payer. But I just look back a few days to an article that was in the Globe and Mail, and generally what was quoted in there from the CFIB was that they are normally very supportive of anything that can reduce, business cost. But they're also questioning about whether they've been able to see that PPNs deliver those savings. And I can't agree with that more because, from the patient perspective, it's hard to exactly see where those savings are. And sometimes for the employers, it's the same thing. I don't profess to be an expert on how a PPN is set up. I've had no experience with that. But I do know that, I come from the Wild West in Alberta, and one of our pharmacies in rural Alberta, every time that they have to dispense a product for one of their patients, that they have to then source from a single source supplier in Ontario, when we dispense it, we lose $480. That is not a sustainable business model. We are doing it for the patient to maintain that continuity of care for the patient. And the patient wants us to continue their care because we're trusted, and they don't want to have to drive into Red Deer to the closest preferred pharmacy. And so, like I say, I'm not an expert, but I'm also working under the assumption that the preferred pharmacy is not losing $480. But I'm very concerned about the sustainability of the business. But more important to me is I'm more concerned about the fractured care that can occur.
Thanks for adding that. Sandra,
Can I just want to elaborate on a comment that Bruce made. So, in terms of some pharmacies losing money on a dispense, just to sort of kind of give background for those who are less familiar with sort of the pharmacy model, is pharmacies acquire all their medications from wholesalers, and we acquire those at a list price plus markup. And in some cases where there are more limited distribution channels or more closed distribution networks, pharmacies are acquiring these drugs at a price lower than what is reimbursed. And so this is where kind of these additional, I guess, system design features make it really challenging to really honor patient choice. Although we're saying we have, patients can go anywhere they want, and pharmacies can, service the patients if they want. These are some of the challenges that pharmacies face when there is a PPN, and it's Sandra, your pharmacy can participate in the PPN, but my acquisition cost is higher than my reimbursed cost. So can I really participate in that PPN? I mean, I can, but does it make sense to? And that's sort of the example that Bruce is giving.
Yeah, I should just clarify, like on the example that I'm giving, it's a publicly funded drug. It's not a private payer drug, it's publicly funded. But because of the PPN, we're losing $480.
So it's interesting to see how, I know this panel is focused on PPNs, but there's a lot of restrictions and kinks in the system right across the entire drug chain, whether it's from a purchasing perspective, obviously a dispensing perspective, and all the additional services that patients might need. But Sandra, you brought up an interesting piece, and I want to get to that in terms of patient choice. And so, Stephanie, I'm going to pose this question to you around how can we ensure that patients can actually choose their own pharmacies, like choose their pharmacies in an informed way?
It's not easy. Patients often don't even know what their insurance itself covers. if there is a PPN, low max, I believe somebody was mentioning before. So part of the journey starts with the reimbursement team educating the patient about what their plan means and what the coverage amounts are for the companies that provide financial assistance, what that coverage will be. And if there is a PPN, again, it's explaining to them what that means and helping them make an informed choice, because all we can do is educate. We're not going to influence one way or the other. And, you know, if a patient wants to use their local MONPA pharmacy, then it's incumbent on the PSP to explain to the patient, okay, this is what it means, you know, whether it's an 80% coverage versus 40% coverage, here's the impact to you because of copay, all of those different things. What is missing is that there's no conversation that happens between the PSP and the patient in the pharmacy that would be accepting that prescription. And it does occasionally happen where a pharmacy will say, I'm not going to accept it. They know that, you know, especially if they're a small pharmacy, it's not sustainable for them. They don't want to break that relationship with a patient, but sometimes they have to. And then there's the occasional time where a pharmacist will say, I'm just not comfortable with that medication. And so those are different things. So it really comes down to having a team that understands PSP, understands PPN, understands the payer landscape, and gives the education to the patient so that they can make the best choice for them with what they have. It's not going to be perfect, but it'll be the best that they can do with the information they have.
I have one follow-up on that in terms of patients being educated to inform their choice beyond the cost. So reimbursement, I think, is obviously one of the key factors there. What about pharmacy services? I wonder about a patient being educated on choosing a pharmacy that can truly support their particular drug.
Yeah. Can I
Yes,
chime in?
absolutely.
I think it's very clear that it's a pharmacist. We're mandated by our code of ethics and standards of practice to dispense those items that we have a competency in, or to go out and get that competency. So I'll totally support where Stephanie is on, if a pharmacist is working at a counter and they have a prescription in front of them, and they don't feel that they have that base of knowledge around that medication, they either have to go out and get it, or I feel like they're bound to refer to another provider that has that competency. But I'll say, I happen to be an infused specialty drug patient, and my experience is, to me, terrible in what we're doing, because I know what the PSP is supposed to be doing, I know what the pharmacy is supposed to be doing, but in my personal experience, I am doing what Stephanie is saying. I'm refusing to procure that drug and dispense it at my pharmacy. Used to be my pharmacy, I sold to Neighbourhood. But I refuse to do that because we would be losing money. But at the same time, I've been on this drug for 5 years, and the pharmacy that is owned by the provider has never once called me, not once. So, you know, I think we just have to be careful about what we're setting up as the expectations in the model that's out there right now, because there are big gaps in that care.
Mm-hmm. What I'll just do, Bruce, is I'll ask you to just piggyback on that and share a little bit about patients, the patients that are in rural, remote areas, and maybe some of the barriers that they would face.
Yeah, I am very concerned right now that, you know, I don't want to think that it couldn't happen here. What is happening down in the U.S. right now, where we have these pharmacy deserts, not only rurally, but in some communities in urban centers. And they're running into, you know, also complex problems, and they have DIR fees and all of the PBM issues. But it comes down to the same thing. As you know, the more expensive drugs more commonly are part of, at the moment, PPNs, where we would be losing money, then, you know, those pharmacies in town are considered to be sometimes the only healthcare hub in that town. But for sure, they are considered to be a major employer in town and a stable employer in town. I'm very concerned about, that we're losing sight that those patients that are out in, rural road or township road trying to arrange for delivery of their medication, if it's coming from mail order or from another preferred provider that's not in town, they have to go out of their way to try and figure out how to get that medication safely. And I know as a patient, I wouldn't want it left on my doorstep.
Mm-hmm. Thank you. Sandra, I'll pull you in here to make some quick comments around the U.S. experience and the Canadian experience that Bruce brought up. So what are some of those learnings, I think, that when we look at the U.S., we can think about and make sure that we shape our own Canadian experience in a different way?
So I think one thing that I'll comment on is how you phrased the last question around informed choice, I think is a really, really great way to position it, because we talk about patient choice, but again, we are all experts in this system, and we have all had an experience where we don't even know where to go to find the care we need or the care that we need for our loved ones. So I think we have a bit of a job to do collectively to inform patients. And that is not only on what is covered for them and not, but what is the type of service that they would benefit from while on that medication, and give them the opportunity to find the provider that will best meet their needs. And that may be the closest one in some, and it may be the pharmacy that they have a relationship with in some cases, and that may be, one may be willing to drive a little further to find that care with a specialist or an expert in that particular disease state or condition. So, but I think what's missing is we're not really giving patients all that information to make those informed choices. And that's really kind of a fundamental principle of our healthcare system, is we want to empower patients to be able to make informed choices, but we don't really do that. And so when we think about PPNs and even PSPs, we don't always do that very well. So I think there's an opportunity for us to work together on that. Going back to your question about the US model, I think there's a couple of things I would say. Firstly, the big media outrage that happened earlier this year around PPNs, and what really brought this to the forefront, really demonstrates that Canadians are very different than Americans when it comes to healthcare. We are very protective of our right to choose. We are very protective of our right to access healthcare, the way we want to access healthcare, where we want to access healthcare. And so I think there are some fundamental differences between Canadians and Americans in that sense. Americans are very okay with being told where to access their care, by whom to receive care, at like when and how. We're not like that. So, but a few really, really important things to note in the US system that are really, really causing concern, that in fact, there are some signals of that in Canada. So, as Bruce mentioned, pharmacy deserts are being created all over the US, and that means that there are regions without any access to pharmacies. There's actually recent stats that have demonstrated that there are 3 pharmacies closing per day in the US. And these are not little mom and pop shops. These are, Walgreens has announced they're closing thousands of pharmacies. Rite Aid, declared bankruptcy earlier this year. We're seeing huge organizations that are shutting down stores because of challenges in the payer space. So I think this again kind of points to my first comment, which is we can't look at PPNs in isolation, because when we look at the US, it's not really just about PPNs. It's pharmacy benefit managers who basically manage all of these PPNs and manage most of the private plans in the US, which is no different than Canada. PBMs, pharmacy benefit managers, are who pharmacies sign agreements with to receive payment from the multiple different payers. And for your information, those agreements are not really, they're not really agreements. It's if you process a claim through this PBM, you are agreeing to all the terms and conditions. There's not really an opportunity for pharmacies to say, hey, hold on, I'm not making any money, or I'm losing money on these dispenses, or this is not sustainable. There's no negotiation. PBMs are basically a conduit to pharmacies getting paid by payers, and we don't really have any choice in the matter. It's really a take it or leave it type of agreement. So that's one thing, and that's the same in the US, but it has caused a lot of concerns in the US because PBMs, and Bruce mentioned DIR fees and things like this. Basically, there are all these non-transparent fees that are being imposed on pharmacies by these pharmacy benefits managers that are creating an environment in which more than 75% of brand drugs in the US that are dispensed at or below cost. So US pharmacies are closing because they are literally losing money on more than 75% of brand drugs. It's a little bit different for generic drugs, but the financial situation in the US is really, really critical for pharmacies from that perspective. And so when we look at sort of the Canada-US, these are things we're watching that are really scary. That we're not there yet, but we don't really have, there's not really any reason or legislation or regulation that would prevent us from getting there, other than the fact that we're just not there yet. That's right. So the PBMs and then the PSP conversations that we've had around just the interdependency between PPNs and PSPs. And then the last part that's really concerning in the US is all the vertical integration, right? Everything is integrated from payer all the way down, from healthcare provider, doctors, every allied healthcare provider, pharmacists, et cetera, is all vertically integrated. Again, in the US, it's very acceptable by patients to go from top to bottom and follow everything they've been told, but that vertical integration is present and is a growing trend here in Canada too. So we're starting to see a lot of these trends that are very pervasive in the US and that are causing a lot of challenges and concerns for pharmacies from a sustainability and viability standpoint. And there aren't really we're not there yet, but there aren't really any reasons why we can't get there. And that is what's causing a lot of concern for us. And so when we look at PPNs, that's part of the challenge, but it's only one part of a much bigger kind of ecosystem of issues that need to be addressed.
I think it's important that I just share what happens where the rubber meets the road. And what Sandra said about the agreements that individual pharmacies have with PBMs. And I earned my spurs as a local independent pharmacy. Neighbourly Pharmacy has 300 pharmacies across Canada. 70% of them are rural or remote. Each of those pharmacies has an agreement, and in the agreement with TELUS, Assure, or Express Scripts Canada, or Green Shield, any of the PBMs. Within that agreement, we're actually told that if a patient presents a prescription and their coverage card, we have to adjudicate the prescription. We have to try and fill the prescription. Goes a little bit against, I guess on professional reasons, we could say, we can't. But it really says that we have to, whether we lose money or don't lose money. But when we hit enter, the only way we know if somebody is covered is we put it through as a claim, hit enter, wait for the claim response. And that claim response, many times every day in pharmacies across Canada, comes back and it says, not a preferred provider. That's all it says. And so I can tell you, in almost every case then, the pharmacist picks up the phone, gets on hold with the help desk, knowing it's a big waste of time because they can't really tell you, but the patient is standing in front of you. And then you end up, after getting through that process, you speak to the patient, you say, hey, on this drug, I'm not going to be able to fill your prescription. And you're going to have to go back to your employer to find out, where you have to go. And they'll look at you and they'll say, well, I don't understand. You've always filled my prescriptions. I trust you. You know me. You know my family. You know the name of my dog, right? It's it's a very personal, professional relationship, especially in rural. But also, I was not rural, but I had multi-generational families. So, it's one of those things where the pharmacy is just caught in the middle. We don't know what happens until we put that claim in, and then the burden is on the patient.
And I'll just add in, there's a lot of burden on the patient if they really insist that they want to use their pharmacy. And the PSP is designed and set up to help patients with appeals. And medical appeals are a matter of due course. But when it comes to employer appeals, it now puts an entirely new burden on the patient, because now they are obligated to disclose to their employer, I'm the one
Right.
that's adding to your benefits plan. And so
Yeah.
even though a pharmacist may want to hop on the phone with the insurance provider, the reality is that there's nothing really that the PSP can do independently. They can try, and they will, but it would require an employer appeal, which now puts the patient at another disadvantage. So there is a bit of a give and take there, and if a patient is part of a large organization and they feel that they'll be remaining anonymous, then it's more likely to move ahead. But when you have, I think I heard the stat was that, was it 70% of all of the plans are with these medium to small employers. When you're one of 25 and perhaps what you need your medication for is visible, and all of a sudden now they know, oh, you're appealing to me, you're $25,000 a year, $50,000 a year, it makes them not want to move ahead, right? So it's not a successful opportunity for them. So they're stuck without choice.
Right. No, thanks for that. I think we've heard a lot around just the multiple different stakeholders that all have a seat at this table when we talk about PPNs, and we spent a lot of time talking about Canadian versus U.S. experience and government. So we do know that the Ontario government is going through a consultation at the moment around PPNs. I think one of the things that is great about it is that they've pulled multiple stakeholders in to be part of that consultation and to provide their experience, their insight, their advice in how what a go forward looks like, when we talk about the PPN landscape. So maybe I'll get each of you, I know that we're coming down to time, to comment. Moving forward, 1 year from now, 2 years from now, where do you think we're going to land with PPNs? And maybe I'll pose it, Bruce, to you first.
Yeah. Well, I have to lean on to what Stephanie just said. The reason for patient choice and patient access is oftentimes to maintain that confidentiality. And you don't want to be the one person, with your employer who is causing an increased spend. But at the same time, I'll say there are very good reasons why employees want to keep church and state separate as far as their healthcare is concerned. And that's why, I think the provinces should look at what the province of Quebec has done in terms of trying to support patient access, lean into, the legislation that they have in place, and I encourage, regulators to strengthen the code of ethics and standards of practice, and then enforce them, so that we know that medication is being dispensed, safely, and that those relationships that are between pharmacy and patient are about care and not about some financial hurdle. And while I'm giving out accolades to the province of Quebec and for Ontario for opening up the discussion, the consultation, I'd be remiss if I don't share that my personal experience with Neighbourly. Several months ago, I started to challenge my own company that I'm working for around what our health benefit plan looks like. And it became, a real dialogue back and forth. But we can't be a pharmacy company and not want to have patient choice and patient access. And so through that dialogue, I'm really excited that Neighbourly has made the principled decision right now to go back and change that policy within the health benefit plan to get rid of that, that incentive or financial incentive or disincentive for employees at Neighbourly to freely choose who they get their care from. And, I can't be more proud of that decision, but it's up to everybody in this room to be leaders and go out and challenge your employers about, we talk about patient choice, but are we really supporting that? And, I'm proud of the decision, even though it comes at a cost to the company, but what Neighbourly has decided to do.
Thanks. So last question, I'll maybe throw it to Stephanie, you, as well as Sandra, you, just a few seconds. Moving forward, looking into the crystal ball, where do we land with PPNs?
I wish I had a crystal ball. The nurse in me wants patients to get access. And for me, when I'm looking at the patients, the number one thing is, can they get treatment? Once they have treatment, then it's my personal belief that secondary is where. And only to the extent that if they can't get it at their first place, the most important thing for that patient is that they get treatment. The collaboration, I think, is where we need to go. We need to break down the silos. There needs to be more discussion. But if we always keep the patient at the forefront of every decision, then you can start to layer on all the nuances. They get treatment. They get it from a care provider that they want. They get it covered the way they want. And these are all things that don't always match up. So my crystal ball says I'd love to see us get there and include patients more deeply in the discussion.
Last word, Sandra?
I'm going to build off Stephanie's a little bit, but there are so many stakeholders involved in the delivery of care, whether it's manufacturers, pharmacists, nurses, physicians, other healthcare providers, payers, benefits plans. And I think we all have similar interests and priorities, but also different ones. And so, again, kind of looking at putting the patient in the center, if there was an opportunity for anybody who touches the delivery of healthcare to come together and align on a set of principles that really kind of put the patient first, and that is, maybe it's choice, maybe it's informed choice, maybe it's best patient outcomes. Whatever it is, I think there's an opportunity for us to come together to align on some of those principles and then build from there. Because all healthcare providers, we have standards of practice and ethics and code of ethics that we have to follow that always, patient choice and, patient-centered or patient-directed and the best patient outcomes and no harm. And we follow those every day. But if every other stakeholder involved in the delivery of care is not following those same principles, how do we win?
So thank you. Thank you very much for such an informative discussion. I want to thank the panelists for their messages today, and I really hope that we all learned a lot of different perspectives and insights around this PPN topic that we're dealing with.
Thanks again to the panel. It's time for lunch, so come back in 1 hour. We have 3 more panels this afternoon before we wrap up. Thanks.